Our last speaker is John Costello. He too is a pioneer in addressing the needs of patients who are communication vulnerable in hospital settings. John is the director of the Augmentative Communication Program at Children's Hospital in Boston. Welcome, John. It's so nice to have you join us.
Thank you so much. It's a pleasure to be here. So what I'd like to do is discuss an overview of what I think we see as being best practices when working with a patient who is communication vulnerable in the hospital setting. And as you can see from the bullet points here, there are a number of things that I'd like to touch upon. First of all providers have to recognize that when communication vulnerability exists. This is accomplished through consistent provider education, recognizing that in a hospital setting, especially in a teaching hospital setting, new providers emerge with fair regularity, and there's a need to constantly remind people of the broad picture of what communication vulnerability is. The second is administrative support for services to address communication. While communication vulnerability is often recognized by bedside providers, it requires administration support, or really a top-down as well as a bottom-up approach, to make sure that there are the intellectual as well as the mechanical resources available to address the needs of patients who are vulnerable. Third, communication access. Looking at access to communication supports from pre-admission through discharge and follow-up. Communication vulnerability can be present through the entire continuum of care, as is the case of a person, for example, with a known communication, sensory, cultural, or language vulnerability. But it might be introduced at some point in care, as is the case of a person, for example, who is intubated and suddenly finds themselves vulnerable for the first time in their hospital stay. The fourth bullet is equipment and looking at the availability, storage, and dispensing. Having tools that meet the diverse needs of patients readily available is key, while it is equally important to make sure the equipment does not become the answer. So it might be important to be sure key tools are available to bedside providers to address communication vulnerabilities when it's identified, but a good clinical assessment of communication needs and a feature match of the best tools and strategies to a patient's strengths and needs is always going to be the driving force. In terms of looking at treating the whole person through multidisciplinary collaboration, it's really important that effective communication and advocacy be recognized as the cornerstone to success in the hospital setting. Whether it is with a clinical assistant, someone who might be helping a person reposition in bed, or someone from the dietary department who's taking a menu order, or with the chief of surgery who is discussing a surgical intervention. It requires that every team member be on board with recognizing that a patient as a person and as a valued partner in communication and decision making must have access to communication at all times. I'd like to highlight many of these points through one case example. The case that I've chosen is a child who is at the time 10 years, 9 months. He's a native of Iraq and came to us with his family from Iraq, unable to speak English, both the child and his parents. The reason for hospitalization was a surgery for spinal compression related to a number of congenital anomalies, and it was anticipated that he would have a tracheostomy introduced during his hospital stay, and indeed had no air leak with that tracheostomy for quite a period of time. We knew preoperatively that he had minimal joint strength, and while he was able to push a switch and use certain types of light touch keyboards preoperatively, it was unclear that he'd be able to access those post-op. In terms of communication needs, what was really critical is that we made sure that parents and the child understood information from the medical staff. We wanted to make sure that the medical needs could be communicated clearly to staff, and also wanted to make sure that the child was able to communicate emotional needs, social kinds of things, jokes to families. One of the things that we've learned from the 20 plus years of collaborating with children and families on selecting vocabulary and looking at communication vulnerability in the ICU and acute care setting is that across the board, the two major complaints that people have when they're unable to communicate is that they feel stripped of their personality and they feel that they don't have control. And by enabling this child to socially engage and tell jokes and also have statements of control, we wanted to assure that those frustrations were not part of the experience. And then finally, we want parents to be able to ask questions about the diagnosis, the treatment, the prognosis, and the care of their child. So general accommodations are listed here, and I'm going to touch upon these in future slides, but we had an Arabic interpreter available for all key periods of learning and teaching. There were English-Arabic communication boards that had been created for the family. Picture communication boards were also available with English and Arabic text over them. The basic nurse to patient family messages, in other words, those messages that nurses have to communicate to the patient and family, were also written out in English and Arabic. And then because of the anticipated difficulty physically with accessing standard call systems, a modified nurse call system was created, as well as a modified system for this child to call attention of his family. In terms of looking at the pre-op technology supports then, in addition to communication boards, picture communication boards, and the text that we had available, we also had simple voice output aids. In the case of this child, we had used a MessageMate because it allowed us to quickly digitally record messages. We recorded the messages preoperatively with the interpreter service, as well as in this case with the child's father. Often we try to support patients to record their own voices so that they can have their voice available postoperatively. And in this case, the father was elected as proxy. So after selecting some of the key messages that were thought to be important for this child to communicate, they were recorded in English and then immediately recorded in Arabic, so that when this child used the system, English would be spoken out so that care providers immediately understood what he meant. But then he would also hear the Arabic so that, number one, there could be confirmation that the intended message was communicated. And number two, the family would also be able to hear and understand exactly what had been communicated. And then finally, in that pre-op phase, we had taught this child to use single switch row column scanning. Again, it had been anticipated that motor access was going to be more difficult postoperatively, so we wanted to make sure we had easy access to this vocabulary. For post-op intervention, we again reviewed all of the tools that had been introduced preoperatively. We then also looked at some changes that needed to be made due to an even more reduced mobility status postoperatively. A larger modified nurse call system had been put in place. Preoperatively, we had anticipated a right foot movement as being the best access site. Postoperatively, it was much easier for this child to use his right elbow. So a large switch had been placed under his elbow so that he could access the nurse call. It was also important, however, for this child to be able to call to family and not always summon the nurse when he hit the switch. So for those times when the family was nearby to be able to pay attention to him and interpret needs, should he have needs, we set up a simple voice output communication aid step by step, connected to that same switch, so that when he used his elbow, he instead would summon his parents with a pre-recorded message in Arabic. Again, they could then come to his bedside, better interpret what he may need and summon the nurse, and then the nurse call system could be used if the parents were not available in the room. There were some unexpected post-op needs as well. As I mentioned, there was minimal movement post-operatively compared to what had been anticipated. In part, once getting back to the intensive care unit because of the influence of medication as well as the influence of sedation. It was even more difficult than anticipated for this child to start out scanning with the single switch. Therefore, at bedside, there was a focus on teaching the parents and teaching the child how to do partner-assisted scanning. Fortunately, much of the vocabulary had been selected preoperatively, and so the message mate display was able to be used so that the parents could simply go through, point to each target, and verbally state what it is. Their son then used his elbow to hit a switch to answer yes, or the parents were actually quite good at interpreting his closing his eyes tightly as a yes. Also demonstrated and reminded them of how the scan would work with the device once he was able to use the switch for scanning. And indeed, as with many patients who emerge from surgery, within a few hours, he was able to independently use that switch instead of having to rely on that partner-assisted scanning. The interpreter had been available at bedside while that instruction was happening, and because it was really important to make sure that when I, the speech pathologist, or other clinicians weren't available, the parents really understood how to implement this system. A teach-back method was used so that after providing the instruction, the parents were asked to talk about what it is that they needed to do. And in this case, they actually demonstrated by demonstrating partner-assisted scanning and then demonstrating the setup of the scan. Added supports for the family are detailed here. As I had indicated earlier, the parents had written down many messages that they thought were going to be important for them to communicate to doctors and nurses. And preoperatively, we had taken many of those messages and with the interpreter had come up with an Arabic translation. Because, of course, you don't know what you don't know, we realized, or the family realized postoperatively, that there were additional messages that they wanted. So we ultimately came up with sheets of paper where those sentences were written out in Arabic and in English so that the family could use those. Similarly, there were sheets that had been made up or cards that were made up for the nursing staff to be able to communicate with the family. So we had many of the common phrases and sentences and directions that the nurses need to provide written out in English with Arabic translation under those. Finally, to support the child, we had picture boards, and we often have picture boards that we use that are custom made here at Children's, but we also have some standard boards for personal care, for medical, for psychosocial needs. And so we used those picture boards and custom boards, and just to make sure there was no room for error, wrote the English and the Arabic messages over those. So the child was able to use those, and both English readers and Arabic readers were able to readily interpret his intent.
Thank you, John. You brought so many key issues to life for us.
It's my pleasure. Thank you for letting me be part of this.
So let me just reiterate some of the major points. Most importantly, of course, you captured for us the reality of being a patient and a family with multiple communication vulnerabilities. This requires administrative commitment and support for patient-provider communication to help these patients. It also requires the importance of trained personnel to support the patients and the providers. You shared with us some of the flexible and consistent use of AAC and AAT technologies, and also strategies that we need to use, like teach back, to ensure effective communication occurs.